Thanks, Kim, and thanks to the RETAC for inviting me back again this year. Certainly, always appreciate the opportunity to get to present to this group. As Kim said, my name is Scott Moore. I'm with Moore EMS Consulting. I am one of several cost education faculty that the AAA has assembled to assist in the efforts to educate ambulance providers around the country relative to the new CMS ambulance cost collection requirements. I think we were out a couple of years ago talking a little bit about this, and many of you have probably seen the numerous programs that we have hosted over the last few years. Last year, due to COVID, everything kind of got put on hold. But for those of you who don't know me, I've been a 31-year EMT. About 16 months ago, stopped working on my town fire department after roughly 16 years. I've been an employment lawyer now for 18 years, HR consultant as well. And for the last 6 years, I've served as the AAA's human resources and operation consultant. So, and have been sort of leading the charge on doing a lot or putting together and doing a lot of the education relative to ambulance cost collection. Sort of as we always do, the American, quick disclaimer, I jokingly say, always trust a lawyer who says, don't rely on what I'm about to tell you. The American Ambulance Association's consultants and speakers do not provide legal, financial, or accounting advice. The intent of this program really is to be informational and educational. If you need legal, financial, or accounting advice, you should contact a licensed professional in your area. So, and having not, I know we've done a bunch of virtual programs. I think I did 68 virtual presentations last year. For those of you who are live, Kim, if you guys in the room there have questions, please just unmute the mic and go ahead and pitch the question. And for anybody who might be online, certainly watching the chat and the Q&A feature. And so I'll be more than happy to try and answer those questions as we go along. Now, I think we did presentations relative to cost collection. So some of this is going to be a fair amount of review. Part of what I just said to someone who I was taking a phone call while we were waiting for the program to start, I feel like a pandemic lawyer now rather than a cost collection or an employment lawyer. I've been spending, probably 90% of my time over the last several months really dealing with issues and challenges around vaccination. So this is a welcome change to get to do a little bit of something else. We just did a presentation, Brian Werfel and I, out in the state of Kentucky for a bunch of Kentucky providers, covering just some of the basics and overview of ambulance cost collection. So a little bit of this is going to be review to kind of get people back in the mindset of cost collection, because we've all been so focused on everything else. That cost collection train is coming down the track. So I want to just get everybody back on the same page, and then hopefully we can plug through this over the next 90 minutes. Just a quick reminder, of course, for years and years and years, the AAA had been advocating on behalf of ambulance organizations to continue those add-ons, that 2, 3, and 22.6% add-on that had been in place really since the beginning or implementation of the fee schedule back in late 99 or early 2000. This was those monies that were furnished to that were added on to the Medicare payments to try and ensure that ambulance providers weren't losing money while doing ambulance trips, or CMS related ambulance trips. Now, I argue that, of course, those add-ons are wonderful, but still, even with those add-ons, not enough to compensate ambulance providers around the country for the care that they provide. But again, these add-ons were set to expire back when at the end of 2018. And with this Bipartisan Budget Act, one of the things that Congress said were, listen, we have strong doubts that the current reimbursement structure is adequate. We have strong doubts that it's not adequate. Let me put a double negative in there. In other words, they felt that the fee structure as it existed without the add-ons were more than adequate to compensate ambulance providers for the work that they do. In fact, they argued essentially, why are the for-profit entities into this? If there weren't money to be made, why are they doing it, et cetera? Well, what they said was, we will continue these add-ons for one more cycle, so until or through December 31st of 2022, but they demanded that an ambulance cost collection program or structure be designed so that MedPAC, the Medicare Payment Advisory Committee, could take a look at that data and understand, are those current reimbursement fee schedule, the current fee schedule reimbursement, is that in fact adequate? Now, under this new requirement, the add-ons would be carried on through 2022. They would require this cost collection. So initially there was an interest in having ambulance providers do formal cost reporting. That is a significantly involved process. In fact, many hospitals have entire departments that do nothing but that. We advocated that for many EMS providers, that would be devastating. In fact, because we know that 85% of the ambulance services in this country only perform roughly less than 2,500 trips a year, 75% perform less than 1,000, and I think it's something like 50% perform less than 500. So the fact of the matter is those rural, super rural, and frontier areas are really representative of the majority of the ambulance services that get billed to Medicare every single year. We felt that, in fact, trying to have a formal cost reporting process would have doomed the entire thing, because there's too many other things on the plates of those people running ambulance services to have to then add something else on there. So what they said was, though, is that they would implement this cost collection system, and that sometime in March of 2023, that MedPAC, that Medicare Payment Advisory Committee, would have to report the results of that payment study to Congress. So one of the challenges with that process, one, as we know, COVID, of course, delayed everything. So when it was first decided, right, when it was first passed, the first agencies were going to be selected in 2019, late 2019, to collect 2020 data and report in 21. Then the second 25% of ambulance services would be selected in late 20, would collect data for 21 to report in 22, and so on and so on. So we got through all 4 quarters of those ambulance services that bill Medicare. Well, of course, COVID delayed all of that. And if they had tried to collect information, not to mention how distracted everyone was due to the COVID pandemic, but certainly I think it'd been very, very hard to convince anyone that the costs that we were seeing during the COVID pandemic were really representative of what it costs to provide EMS in this country. Now, one of the things that I say to folks all the time are, why are we still talking about cost collection? Well, as many of you know, none of the monies that were made available to EMS or throughout the pandemic were actually directed specifically for EMS. In fact, when those distributions occurred, we know a lot of people got a bunch of money jumped in tranche 1, but those monies weren't directed specifically in EMS. They were directed at any healthcare provider, Medicare healthcare provider. And in reality, had EMS had a longstanding established cost collection or any sort of cost-related data that we could have furnished to lawmakers during the pandemic, I'm confident that we would have received very pointed and directed financial assistance throughout the pandemic. So one of the things that we're saying is, does anybody, first of all, I don't think any one of us back in, let's say, January, February of 2020 would have predicted what was coming down the path for us. But certainly I think at this point, what we can say is, one, anything can happen at this point, number one. Number two, I think it's highly likely that not only will the pandemic be around for quite some time longer, but that it's probably not the last time something like this will happen. Given that that's the case, we need to ensure that there is an adequate data collection system so that we can advocate and get very directed financial relief for ambulance services. So there was a proposed, or what are now final, rules changes to the ambulance cost collection system. So back in early July, CMS had posted some proposed rules that, based upon the feedback from not only the American Ambulance Association, individual ambulance providers, but also many other interest groups around the country, they made some modifications. A lot of it, we've been working very, very closely at the American Ambulance Association with not only CMS, but also their contractor RAND, who is charged with building this cost collection system. The now final changes made some, small, what I think beneficial changes to some of the organizational characteristics, some of the shared services definitions, service area, et cetera. If you want to take a look at the proposed rule, I did send all of these slides to Kim, I think a couple of nights ago. The links inside the slides should be active and good. So if you go into the electronic document and click on the link, it should launch to get you where you need to go. If for whatever reason it does not, Certainly you can email me and I can send you a live version of the PowerPoint. It is a bunch of slides, so that's why I didn't send the whole PowerPoint, but certainly you can also just type in the address that you see at the bottom of the page. Now, one of the things that the now final rules did was it did change. So because of the pandemic and because they delayed, the year 1 and year 2 and year 3 agencies were all going to be collecting data in 2022, reporting that data by May of 2023. And that would have been not only 3/4 of the industry, but again, as I said earlier, the report to MedPAC was going to be due in March. The first agency's reporting will not be until May of 2023. We advocated to push the entire cost collection system, maintain the 4-year data collection, and just push it back to start this coming year in 2022. But that is not how they went. What they decided to do was, rather than having 3/4 of the agencies represent or collect data in 1 year, they're going to split it in half. So years 1 and 2, who are already selected, maybe many of you that are attending the program today, you will collect data starting in 2022, either calendar year or start collecting at the beginning of your fiscal year. So if you're running July 22 through June 23, that's fine. You can start collecting at the beginning of your fiscal year or at the beginning of the calendar. Those year 1 and 2 agencies will collect data 22, report in 23. Years 3 and 4 will be selected and will collect data in 23 to be reported in 24. The bad news is, by the way, that report is still, MedPAC boasts that they never miss a deadline. That report is still going to be due to Congress right now in March of 2023, 2 months prior to anybody having reported any data whatsoever. We are working on the only folks who can change that would be Congress. So we are working right now on getting that changed. But this, even though it's a little bit hard to read, will show you that 2021 proposed rule will show you how the collection period will go. So if you are unsure if you've been selected, on that last page, well, actually on this next page, you can go here or you can Google or just use whatever search engine you use. You can just type in CMS ambulance resources. Up will come the CMS ambulance resource page. You'll be able to go on there. You will see a link for cost collection. You can go ahead and there will be, right now, there are only year 1 and year 2 files in there. They are Excel spreadsheets. What I will tell you is there's NPIs, there's ambulance service data addresses, not only zip codes, but also states. Now, what I'll tell you is the electronic sheet is sorted by state. Now, some people have said, oh, I wasn't selected, I searched my state. But what it turned out is their billing agent actually is in another state. So they thought they weren't selected, but for whatever reason, Medicare had the service's address as the ambulance billing services address. And so you may very well have been selected, but you may not actually know it, or you should actually search by your NPI, your National Provider Identification Number. I've also had a bunch of services tell me that their billing agent is going to take care of all cost collection. And I'm going to tell you in a minute why that may and probably more likely will not work for you, but we'll get there when we get there. So why is cost collection really critical to EMS? Again, comes back to this idea of without data, everybody else has just got opinions. So one of the reasons why we think this is critical is because really this is the first opportunity since 1999 that we will have potentially reforming the payment system, not only just the payment system, but also some of the methodology. So this is an opportunity to kind of hit a reset button on the way that things are done now. We don't know whether, in fact, that 2, 3, and 22.6% is in fact distributed correctly. We don't know if, in fact, it's actually covering that cost. What we're looking for is, this is the first opportunity since 1999 to go ahead and reform this entire payment system. It is probably the last time for many of folks in my age, in the 50s age, which you may get an opportunity to actually have an impact on how this payment system or methodology for EMS is done. It does open the door to continue some of the innovative things that we've seen. We know the pandemic has brought us a bunch of innovative opportunities, treatment in place, et cetera. This opens the door because with data is the only way we're ever going to move the needle on innovation. Treatment in place, telehealth. It is an important step in our evolution. A lot of organizations, if you go into a healthcare institution, what they will do is they basically can tell you almost anything by looking at their extensive data set that they capture. One of the things that EMS has not done very, very well has agreed upon a, sort of a generally universal set of terms and definitions, and done a good job at showing their value through data, right? A lot of folks will say getting a patient who's having an ST elevation MI over to a cath lab earlier saves tens and hundreds of thousands of dollars down the road, but truthfully, we don't have a lot of data tied to that. So it is really important. This is a normal step in evolution. This is no differently than kind of the 5 whys. When a kid, if you have a 2-year-old, basically you know nothing because they keep asking you why, and you suddenly realize that you actually make up most of the crap that you tell your kids. The fact of the matter is, without data, we're really in no position to be able to advocate in a meaningful and impactful way. This, again, it's important. I know a lot of you on this webinar are engaged, but for every one of you that is on the webinar or on the program or attending the conference live, what you know is there are probably 5, 10, or 15 ambulance leaders who are not in the room, who are not engaged. They don't believe either that it's worthwhile or they just don't have the time. And so what I would say to you is you need to engage those folks, because we will be judged by the absolute worst of the data submitters. And what I will say is anybody who doesn't submit their data will suffer a 10% penalty on all Medicare monies received in the following calendar year. So if you can take a look at what you billed and got from Medicare last year, you should just take 10% and you're going to know what that dollar figure cost you. What I will tell you, I caution you against just taking the penalty, because understand, when doing data aggregation, again, they will throw away the outliers. If the small rural services, super rural services, are not represented in that data set, the only people who are most likely able to produce data, it will be the big for-profit entities. I'm not saying that they're wrong. I'm just saying that their costs are highly unlikely to be representative of your cost. In fact, I'm going to presume that they figured out a way to do it cheaper. Maybe not better, just cheaper. You do not want to be judged solely by their data. And in particular, if you're a municipal entity, I think by and large, we can suggest generally municipal entities provide EMS very well, but often at a cost higher than that of a private EMS provider. That's not a good or a bad thing. It's just a fact of life. What I would say is if we don't have all of those folks present and all of their data present, we will be judging and having policy drafted based solely upon those who chose to participate. That's not necessarily a good thing. We've already covered this. Most ambulance services in this country are small. Truthfully, what happens is the biggies tend to drive policy, when in reality, it's the rural and super rural frontier area folks who should be driving policy. Because ultimately, at the end of the day, if all of the volunteer groups go away or some of these rural providers go away, somebody's going to have to get paid to do that work, right? And probably at a cost higher than it's getting done right now. So recognizing it's critical that the small rural, super rural, and frontier folks get involved. You do need to have someone who's the champion of this process. You cannot and should not, absolutely should not, put yourself in a situation where you decide you're going to wing it. That is a recipe for disaster. Just like anybody, if you've ever been CAS accredited, you need a CAS coordinator. You need a cost collection champion in your organization. In reality, you should have a vice champion as well, because if something happens to the champion, say they get run over by a bus, and it's never anything nice. Let's say they retire and go somewhere nice. Then you want to have someone who understands what the heck is going on. You do not want to, this is not something you can cram on. So you should make sure that you have a champion and a vice champion, and do yourself a favor, have those folks write down what they've done. Because while this is currently slated to just be through 2024, recognize once we start collecting data, I find it very hard to believe that CMS is not going to continue this process in perpetuity. And truthfully, We probably want them to, because in most instances, as our costs increase or change or evolve, we're going to need to be able to produce data to advocate on behalf of our industry. One of the other things that I will say is recognize that as data is being collected, famous saying, data is like trash. You sure as heck better know, if you're going to collect, you sure as heck better know what you're going to do with it. Understand that while we want to use this data to advocate on behalf of ambulance services, this data will be publicly available through, through FOIA and others. CMS will make this publicly available, and not your individual data, but the aggregated data. And I am confident that insurers, private insurers, and others will be seeking this data to try and set their payment policy. So recognize, if you don't engage, and in fact, the only people who do engage are those, are those who can and can afford to, recognize that it's very possible that this not only will impact your CMS money, it highly likely will impact all of your reimbursement. And so it's really, really important that you engage on this. Just before I move on, any questions so far? Kim, I know your camera's off, so I can't see the group, but I'm going to, unless I hear any interruptions, I don't see any questions in the thing, I will keep rocking.
We do have one question.
Okay.
On, Scott.
Go for it.
Yeah, I was just wondering, I've actually heard agencies say, you know what, we already give them the data. We don't need to do extra work. We give it in the form of NEMSIS, and that should be good enough. Yeah.
So great question. So NEMSIS captures, we all know there's sort of a basic NEMSIS data set. However, honestly, and I don't claim to be a NEMSIS guru, but what I will say is, it is my understanding that the NEMSIS data does not collect the data that the CMS cost data collection is going to be collecting. So what I would suggest is, I do believe that there is a delta, or there are, in fact, actually very limited areas in which there is overlap. So there might be some dispatch data, sort of where your calls are occurring, that kind of stuff, but they're not going to have the cost related data. They're not going to have what your labor costs, which is the largest cost you're going to have. They're not going to have necessarily what your vehicle costs, your fuel costs, all that stuff. They're going to have generally the stuff that gets submitted through and when PCRs get submitted to NEMSIS. So does that answer the question? Or are you more or less suggesting, and this is part of what we need from you guys, is, are you more or less suggesting, hey, you need to understand that this is something that is a threat to a meaningful cost collection or a robust cost collection system?
No, I think it's just a misconception.
Okay, but no, I'll write that down and I'll add it into the notes, because I think it's a great point. I think a lot of people not only think, geez, we submit a bunch of data through NEMSIS, and every state EMS office has a certain amount of our data. The fact of the matter is, this, just like, and even some are saying, well, we submit our costs, our financial data to our Medicaid office as part of our yearly audit or whatever. The fact of the matter is, those are, or GEMT, those are not the same thing. So I will, I think that's a good point. I will make sure, and I appreciate you making that. Any other questions?
I see none online and no more in the room. So
and I want to say,
Scott.
I have to tell you, I would way rather be in front of you all than looking at another screen.
We wish you were here also.
Well, one, I've only ever been to Colorado because you guys have invited me, and I think I've been in and out in less than like 24 to 36 hours. One of these days, I want to come out and actually see more than the hotel and the road between the hotel and the airport. So hopefully one of these times, maybe next year, we can all be in person. But in any event, so EMS Amber, but by the way, I think Kim had offered for me to come out, but there was some limit in the amount of time of travel, because I did a session today for the Canadian EMS chiefs on vaccination. And so, Kim, thank you for accommodating my being remote. But next time, my hope is that I will be standing there with you all, because usually there's a beer thing that occurs the night before, and that's really part of the benefit. So in any event, so Amber is one of the things that we talked about at the AAA, and for those of you who don't know, I am a contractor, much in the way that Brian Werfel is a contractor to the American Ambulance Association. I'm not an employee, but I am an independent consultant that works with them and has an agreement with them. I've been working with them now for 6 years. They just re-signed my agreement for another 3 years. Hopefully, we're able to continue to evolve and do more stuff. But what I will say to you is early on, we recognized that at the pace that this thing was going to be done, that we thought that it was highly likely that the first time any ambulance provider was submitting data or really using that electronic interface that CMS is currently having developed by RAND, or the software company that RAND has hired. We were concerned. One, we didn't know what that interface would look like. Two, we also know that when you submit that information, there's some concern that maybe it wasn't done correctly, or you might have put it in, you might have put in more, there might have been decimal point issues. We talked about the need to have a platform where EMS providers could start to work with the tool, understand what was being asked, hopefully have really robust help menus, and potentially have automatic launching, educational videos, etc. At the time that we started to build Amber, we had basically 6 to 8 months to build Amber because of the timeline. COVID has presented us with an opportunity. Had we started building, and I say we as their contractor, but it's easier. Had AAA started building, had we known about the delay when we started building the software, we would have built Amber from a transactional QuickBooks-like manner first for EMS, and then gone to the reporting side. But because at the time we knew we had a very short window, they developed what would essentially be an electronic version of the tool that CMS had published, with additional augmented features that would allow you to make sure that you knew when you clicked on that little question mark, that little mouse over question mark, it would tell you, here's what you're supposed to put here, here's what you're supposed to put here. The other thing that we built into Amber, the developer did when it was being done, was some logic that would basically say, hey, you've put this here that's inconsistent with here. Did you mean to do that? We hope that the CMS tool will do that so that you don't inadvertently make a mistake. There is going to be certain logic in the tool, that tool being, it's on the website, it's on that AAA resource page. It's just a PDF version of what will be an electronic version. It's very hard to work through because there are a lot of bolded and bracketed things that are trying to tell you how the electronic side of it will work. So in that tool, they will have some skip logic. So if you said you're a non-fire-based EMS system, then it will not ask you questions about being fire-based, right? It won't say, hey, you won't see things about those folks who have fire or police responsibilities. If you've said you're just an ambulance provider, and what I mean by that is not, oh my God, you're only an ambulance, but you're not providing other services, then you won't end up seeing questions relative to fire or public safety based or hospital based ambulance services. You will only see those that fit your category. If you have filled out those questions, and we'll talk about those in a minute, and then later on in the tool, you're a non-fire based EMS system, but you're seeing questions about individuals who have public safety obligations, you've definitely answered something wrong earlier. So Amber was designed really to attempt to give a platform for folks to get used to this, number one. Two, for us to be able to, in a de-identified manner, so AAA has no access to your individual information. I've seen the contract, I helped draft the contract. There is a firewall between the developer who's hosting the platform and developing it and the AAA. They will only see aggregated, de-identified data. The reason for that is when people are collecting data, not only can it be used in your favor, it can be used, as I said earlier, against you. We want to be able to prepare in the event that as we're looking at data, we can not only build a defensive strategy, an offensive strategy, but a defensive strategy. So if you haven't yet done so, and you are a member of the SAVIC buying group, which membership is free. So if you're not a member of the SAVIC buying group, you should be. It's free. There are great collective purchases on there, not only for you and your organization, but your employees, like travel benefits and that kind of stuff that they would get because you're a member. But number two, if you're a SAVIC member, you also can apply for the AAA SAVIC Foundation grant. That grant provides access at no cost to any grant. Anyone who applies for the grant will get access to Amber and the education and those resources tied to cost collection. So it literally is risk-free. You should do it. There is no reason not to. I know when they say, if you give stuff away, people don't value it. What I will tell you is it absolutely makes sense for you to do this. Over time, we believe that Amber will grow into a system that will allow us to really to have a robust data set at any one time that we can then, be able to advocate. As many of you know, there are currently some balanced billing provisions that are going to impact ground ambulance. And had we had more data, we would be in a far stronger position to advocate on behalf of EMS. But so there are just a million reasons to do it. Just as we said we would do during this presentation, I'm going to, in certain circumstances, take you back to the Amber platform just to show you a little bit of what you will see if you subscribe and start using Amber. This is the home page that one gets. This is at that EMS Amber. If I go back one slide, emsamber.com. Now you won't be able to log in unless, of course, you've applied for the grant, you've become a SAVIC member, applied for the grant, and gotten the grant. But again, it's pretty straightforward. So this is the home page where you would then log in. As you log in, as you can see, there's the ability to add an administrator or two up here at the top. I'm sorry, managing users. This is not active links. These are just screenshots. There's an encyclopedia. One of the things that we do know, home health had cost reporting put upon them back in the late 90s because their industry could not agree on a universal set of terms and definitions. They have been eviscerated. Every year for the last 20 years, home health has had their reimbursement cut. We want to prevent that. We want to make sure everybody's talking on the same page.
Scott?
Yep.
Go ahead, Eric.
Yeah, I have a question. If you're a AAA member, don't you also have access to that, or do you have to go through SAVIC?
No, I believe if you're so it's a great question, and I want to double check. Early on, before the partnership with SAVIC, AAA members and others had to subscribe. It was a paid subscription. When SAVIC came in and offered some money to build this grant program, it truthfully, and I personally have developed a piece of software myself, and so I know the amount of money that SAVIC offered was wonderful, but it did not cover the costs of those. What AAA realized early on was, again, without a robust data set, without universal participation, we're only going to probably stand to lose. So I believe if you're a AAA member, you get free access, but I can double check. That's a good question. I believe you do. Early on, there was a point at which it was, hey, if you can afford to pay for it, you should pay for it. But truthfully, I know anybody who applies for the grant, as I understand it, will get the grant. So, it's a good question. And I honestly embarrassed. I should know the answer to that. But I believe if you're a AAA member, you get access automatically. But certainly, I'll swing back around. And as you see me turn my head, it's not because I'm ignoring y'all. I'm just writing notes. So
According to their website, you get access if you're AAA.
He
Yeah.
just said that according to the website, if you're a AAA member, you get access.
that's what I thought. Truthfully, I thought, and made sense to me because if you apply, by the way, for the grant, anyways, you get membership with the grant. I think you get 1 year of membership with the grant too, just so that you can hopefully get a taste and hopefully join the AAA. The one thing that I've realized in the many, many years I've worked with AAA now is, while there are 700 and some odd members, there are almost 14,000 ambulance services in this country. So, power does come in numbers. And so I think it benefits and behooves, all ambulance services to be part of that group. This past year at the annual conference, which just occurred two or 3 weeks ago, we actually was the first time I've ever seen representatives of the International Association of Firefighters, NAEMT, the National Registry, a whole bunch of groups that would never have likely been in a room together before. We're all working together on some of the workforce challenges. And truthfully, it was the most encouraged I've been in 31 years of being in EMS, and really 17 years of working with, being involved in the AAA, and then 6 years of actually working with the AAA. There is a universal understanding that the delivery of EMS in this country is under serious threat. That picture behind me up there with the ambulance getting the drape pulled over it is from a New Yorker magazine article that talked about how small rural and super rural ambulances are closing around this country. And I felt, I saw that picture and I thought it was indicative of what we know is happening all over the country. I don't know what's going on in your state, but I would imagine that there are many, many rural or super rural or even urban services that are in significant financial or other stress. And truthfully, we're at a point where I think there needs to be some intervention by the federal government to augment. And I mean, I think the days of zero subsidies, the days of lack of funding are going to quickly come to a close, because ultimately EMS providers are the ultimate safety net provider. And I think you guys already spent some time with Asbel today. And I could do my best at, you know what, but I won't. What I'll say is, Asbel's got some great data on really how EMS is functionally the first, the safety net or the introduction to the United States healthcare system. And so I think there needs to be some recognition of that as we move forward. So thank you for that. Yes, so if you are a AAA member, you get access. This is that CMS.
One more quick question, Scott.
Oh, sure.
Sorry
Go
to
ahead.
interrupt you
Sorry, I
again.
can't. If you want to turn the camera back on, I may be able to see people waving, but go for it. Yeah.
I kind of actually control the system, so
Oh,
we'll
I
just
got
stop you. Go ahead, Chris.
No, so I was actually just wondering, any lessons learned from the home health care data collection, like, so that doesn't get repeated in EMS?
No, it's a great question. So I had inherited cost collection. I was hired 6 years ago as the HR and operations person, but because at the time, despite the fact that I thought workforce was the biggest challenge, the AAA was very focused on reimbursement. And so when this came up, I offered, sort of pitched in, and I researched that home health issue. It was a couple of years ago now, but pretty in depth. And what I will tell you was what the overwhelming response was: one consistent set of terms and definitions. That's why when you look at the cost collection tool, there are a lot of, this is what we mean, this is not what we mean. And so when you go into Amber, you will see what we called an encyclopedia. And it was because we were sort of apprehensive to call it just strictly definitions, because that's not really, it has more than that. So that, I think, is the single one participation, even though it's mandatory in home health. But two, it's, if in fact, as I say to you, give me your labor hour costs, and that is not universally defined amongst all providers submitting their, when I first became the AAA's consultant, I asked if I could do a survey on turnover costs or a cost of recruitment and retention. And I got 35 people responded to my survey. I think I had 5 usable pieces of data, right? Because, when you get through all the outliers, you got to toss stuff out. And I had such a variation over what does it cost when an employee what's the cost to hiring an employee, from $500 to something like $12,000. And I was like, there's no way you have that wide of a variation in some of that. And I even gave definitions of what I mean, what cost to hire was. So I think your question's really, really, really good, a really good one. It is universal set of terms and definitions, making sure we're all trying to measure or furnishing information defined the same way. So a great question. Any others?
We're good.
All right. So this is that page on CMS's webpage. If you just type in CMS ground ambulance data collection, you can do that. You can type in the ambulance services center. This is that page. It runs on for quite some time, so I just snapped a picture of it. But what I have to say about CMS, they've done an unbelievable job in putting together resources and education for ambulance services, whether they be public, private, or otherwise. What I will say is, this is a page that I go on regularly. They have not only the video and audio recordings of these presentations, the slides. It's excellent. I mean, honestly, I applauded them when we were on a call with them. By the way, with Amber, we've been on the phone, we've been on calls trying to get them to either do one of two things: allow Amber to have an application program interface or an API with whatever system ultimately gets designed to be the CMS data collection. So in other words, if you're an Amber member or user and you want to submit your data, there would be a button essentially in Amber that would say submit data to CMS, and it would electronically speak to the CMS system. Alternatively, we're working with them on this because we want this to happen. They're always a little wonky about data, anybody that's pushing data to their system, but we've said, listen, we'd let them look at the system. We did a demonstration for them. There were aspects of the system that they're like, we think that's the coolest thing ever. But alternatively, if they won't let it be a direct API, they've said that they would likely make provisions or functionality in the new system, their system, that would allow a CSI, oh my God, I'm having a hard time today, a CSV file upload. In other words, Amber would kick out a CSV file. In other words, there'd be a button in Amber that says, create file for CMS cost collection. It would kick it out in a format that we and they have universally agreed to, that then you could go to that system and you could just upload the full file without having to re-enter anything. Worst case scenario, we will have a report or a reporting system that will essentially, if you're using Amber, to kick your data out into a report that would then allow you to essentially go onto their system and just take the numbers. And what we would have in there is where they've said, kind of like your 1040 EZ form, when you go to do your TurboTax, it says, take, from your W-2, box, 8A, take that and put that here. That's what we'll do. So there will be multiple ways in which it may be really beneficial to use Amber. But again, back to this page, unbelievable. So if you're a public safety entity, they have numerous open door forums where they talk specifically about how that labor issues can be a challenge and how to report that. They have a lot of algorithms and a lot of resources that, in fact, some of which I've logged into or included in this presentation. So the cost data collection instrument is there on that page. The most recent version is July 31 of 2020. There will be a newer version. Yep, go for it.
Tim? In this platform.
Tim and I like to spar on questions. I'm ready, Tim.
Yes, in this platform, have they helped develop a formula to value volunteer labor for cost reporting?
Great question. So what they've told us they're going to do is so for those agencies that are volunteer labor, you will be reporting the hours and any monies. Now, just because they're volunteer doesn't mean the organization doesn't have costs for employing them. They say that they're going to be able to utilize data from like zip code and or ambulance provider for those who actually provide. In other words, they're confident that they will be able to impute pretty accurate values onto the value of volunteer labor. So it won't be something you'll have to do. It's something they're saying they will be able to ascertain by doing analysis of data in sort of like areas. Does that make sense, Tim?
Very good, thank you.
Okay, good. All right, so the cost collection instrument, as I said, the most recent one up there is July 31st. Because the final rule will be final, they should be publishing a new one. My guess is December 1st, but certainly no later than the end of this year. I also think it's highly likely in the next 2 weeks, I guess possible in the next 2 or 3 weeks, we'll see the group 3 participants selected. Because they've now had year 1 and year 2 reporting on 22 data, that does give CMS a longer window to nail down year 3 and 4. However, my gut is we'll see those lists published pretty soon. Just keep your eyes open. Once they're published, we'll make sure that we get that information out to you. The tool, as I said, they have a printable version. This is because they're convinced, by the way, that a lot of folks will try and fill out the printable version. I'm not so sure that's true, but I think it is a good indication so you can get a look at the tool. It is 13 sections, roughly 45 pages. The first section is instructions. This is kind of like when you have a test and you realize that the first 2 or 3 questions are actually just instructions and you don't have to do anything. So section 1 just really tells you, hey, this is what we're trying to do. There's some general survey instructions. It does ask you some foundational questions. It does tell you we only want information related to ground ambulance service. So if you're an air provider, we don't want that information, et cetera. All right. So this is the general survey instructions. They do say by the way, that this is NPI based. So if you're an organization that has multiple NPIs, you are going to be selected by NPI. So if you have two, you may get selected 2 years in a row. You may have to report on two years at the same time. But what they want is data according to each NPI. So you will have to segregate that information. Most people don't have multiple NPIs. The other thing they say is they're only looking for ground ambulance data, not any other kind of ambulance data, just ground ambulance. They say, according to their experts, that it will take you 20 hours to review the instructions, collect the required data, and another 3 hours to actually enter, review, and submit that information. They did even come up kindly enough with an estimated cost for this. In my recollection, it was like under $3,000. I say hogwash. I think it's going to take a heck of a lot longer than that. But this is some of their experts telling us that they think it'll take roughly 20 hours. Well, 23 total if you look at the way it's put up. If you're not sure, one of the things that we're telling everybody is go on the PICO system, the provider enrollment chain of ownership system. If you use a billing service, they probably do a lot of your revalidation and probably have your logins for PICOs. You just want to make sure that all the information in there is accurate. Now, you know you're supposed to go in there and update your information if you have a change in practice location or you add vehicles, remove vehicles, etc. That's the kind of thing that if, may very well be your billing agent does it, but you should go on there and make sure that your information is accurate and up to date. They are going to ask you questions in section number 2, which is about your organizational characteristics. This is about putting you in the correct bucket, right? In other words, you don't want to analyze or compare a private ambulance only system to a governmental fire-based ambulance system. You wouldn't want to put a rural system or a super rural system compared to an urban system. So what they're trying to do in these first initial questions are make sure that you end up in the correct bucket for data analysis purposes. The other thing that this will do is this sets up the rest of the tool. So here where it says, do you bill for ground ambulance services? If you say no, survey is over. They will ask what your ownership structure is. They will ask if you have more than one NPI. They will ask for an organizational contact. That's the person that you want them to contact in the, relative to this data collection instrument. They will also ask you, and you should have, for those who are already selected, you should have already told your intermediary whether you will be reporting your data on a calendar or on a fiscal reporting year. Honestly, they don't care which, but you do need to notify your intermediary. If you were already selected and haven't done so, reach out to your intermediary and just tell them, ask for the CMS collection unit or their contact person, and just tell them that you want to notify them. You need to notify them that you failed to notify them of whether you're calendar or fiscal, and that you want to notify them that. If you don't say anything, they're going to assume you are a calendar year, which if you are in a fiscal year, that is a majorly pain in the backside, because you are going to have to, basically cut portions of years from your 2 fiscal. So just call them up now and tell them that you're which kind you are. All right. As I said, these responses set up the remainder of the tool. So if further in the tool, you see questions for the type of organization you don't belong to, you likely made a mistake earlier in the tool. In Amber, you will get alerted throughout Amber when you make mistakes like these. It will tell you. All right. Organizational characteristics. Are you a shared services model? So in other words, are you, for example, a hospital-based system or a fire-based system, where, in other words, that there are costs outside of the ground ambulance costs? Often municipal providers are like this because they have like folks who work in fire prevention who never go on ambulance calls. Those are costs not tied to your ground ambulance. Those are shared services. So your HR department necessarily, or whoever your HR person is, a portion of their overhead will apply probably to the ground ambulance, but a portion of it will not. They will ask you for air. If you are air only, all right, then they're going to kick you out. They're going to say, you don't need to fill this out. But if you also do air, they're going to say, hey, you're an air provider. I don't want any data tied to your provision of air services. But if you have a situation where your air is grounded and you get in a ground ambulance, I need your data relative to that. If anybody in the room is an air provider, or anybody on the session is an air provider, you need to know now that you are going to have to be able to segregate out your ground ambulance costs from all other costs. All right. So if it's partly or entirely related to ground ambulance, you're going to include it. If it isn't partly or entirely related around ambulance, you will not include it. You will not report it. They do ask you if you use volunteer labor. The reason they asked the question here, they've said quite openly, is because they thought a bunch of providers wouldn't think that they had to fill it out if they use volunteer labor. So this question is to make sure that you know you are included in this survey. They will ask you if you do 911 or non-emergency medical transport or both. Again, making sure you're in the right bucket. Tim, what do you got?
Shared services, how does ground ambulance and community integrated health or community paramedicine, is that considered a shared service?
That's a great question. So I don't believe, so even like if you're doing community education, it's not a shared service, but it's not a cost that you would otherwise report, right? So if I'm doing CPR education for the community, right, technically that's not related to ground ambulance services. All right, so that would be a cost you wouldn't be reporting. I see you getting back up. Now, what I would suggest is on the community paramedicine stuff, if you are using both your paramedics for both community paramedicine and for 911 response, you're going to need to, I believe, and I'll double check with the rest of the faculty on this one, but let me just MIH. I believe you would want to peel those costs out to the extent that you can.
Okay, thank you.
Yeah, that's a great question. And I like it. I like the videos back on. It lets me know, because I know, like I said, Tim and I sparred at the last meeting, and it was the best conversation I ever had at most productive bar conversation I've ever had, just for the record, but it was great. And he really challenged and made us think about some stuff that we hadn't considered. So hours of operation, they want to know if you're a 7-day a week, 24-hour-a-day operation. Why? Because those folks who get to close the doors, I know a service that shuts down at midnight, at 11 o'clock. Imagine how great and easy it would be to run a service that literally says, so sorry, we're closed, come back, like a little clock on the door with the thing that says come back at 7 in the morning. That'd be awesome, right? You get to sleep a whole night. And paramedic intercepts, this is not, I know we all like to use the term paramedic intercept, but in fact, this is something specific to New York. All right, it is not what we might normally call a paramedic intercept. Other places in the country, we would call a joint response. All right. So just paramedic intercepts. If they ask about paramedic intercepts and you're not in the state of New York, this isn't you. All right. So this is just to give you an idea. What I did is, as we go through the tool, I kind of show you the corresponding page in Amber. All right. But I don't go through the whole thing, because it's actually all of these things down the left-hand side in the black box are different aspects of the tool and different things that you can click on so that you can start to work through the tool. You can work through portions of the tool at different times. You don't have to go in order. This will ask right here, as you can see up in the upper left-hand corner, right next to the Amber thing, it's asking you what year's data you're reporting. All right. And here you can put reporting period start date. And then you can go through, is this a new NPI? You just would go through and answer these questions. As you save it, all right, it advances you on to the next tool. All right, again, what type of ambulance? Or are you independent, primarily just EMS services? Does your ground ambulance service share costs, building space, personnel with any of the following? All right, so as you go through, the tool is designed to help you out. So one of the things that the sections 3 and 4 cover really are service area and response times. They want to know what your primary service area is. And that is the area in which you exclusively or primarily are responsible for providing service at one or more levels, and where it is highly likely that the majority of your ambulance transports, your transport pickups occur. Okay. This is done by zip code. All right. In the Amber tool, there's sort of a select button where you can draw it in. In their tool, we're told there will be a multi-select zip code selector. It is entirely possible that you and another service also share the same zip code. That is perfectly fine. All right, but basically you should do is take a look at where your transports occur, and wherever 51% of your transports occur, generally that is going to be your primary service area. And they will ask you if you are the primary emergency ambulance provider in most or all of your primary service areas. Again, that's pretty straightforward. There can be multiple, by the way. There can be. In the city of New York, there are primary ambulance service providers, emergency providers that overlap in certain segments or boroughs of New York City. Then they're going to ask you about your secondary area and your response times. That secondary area and response times are those areas, those calls or transports or service area that is outside of your primary ambulance service area, right? So in other words, but one where you regularly go. So what we're talking about is you go through mutual aid or auto aid. So, hey, come over here and help us. This is not it's not somewhere where you go all the time, because if it's somewhere you go all the time, and I mean all the time, you'd be in that 51%. But if you're mutual or auto aid agreements, then generally speaking, this will be your second. We're not looking for those instances in which you get activated by, let's say, your state, disaster response or FEMA. All right, those are outside of your primary or secondary service area. All right, again, here you can do a zip code select. You can click a whole county or parish or state. All right, the other thing that you can do that they absolutely loved was that you can go on here and draw a line of where your service area is with the mouse. And as you go, you can click, 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 click. Now, if you select a county, it will take it'll go out to the postal the zip code file, and it will auto populate all of the zip codes in that county. Even if the zip codes in that county might cross over for whatever reason, if you want to draw it in, it will then grab all of the zip codes in whatever area you drew. This was the part that they absolutely loved. They thought it was super cool. So it's going to ask you about your service area and response times. This is your average trip time, time on task. This was actually time of task is not the right thing. There's a typo, time on task. What's the average trip time in minutes across all service levels in your primary service area? And that's from the time the ambulance begins the response to when that ambulance is available to take another call. This is really important. My friend Gene Bradley runs a service in the rural Missouri, almost 1,300 square miles with 2 trucks. He transports to Nebraska. They're out of pocket 90 minutes one way, out of pocket 90 minutes back, unoccupied. That truck, time on task, if it's 90 each way, is really 180 minutes, right? Because they're not eligible. So in some dispatch systems, when somebody clears a hospital, but they're still not back in service area, it makes it look like that unit is available. You need to have something set up in your system that will identify when is the truck available, how long was it committed, and then able to take another call. So if you have long transport times and people are outside of their service area, you are going to need to start capturing the time that they're available, to take another call. Yep.
I should have let you finish your thought. My question was, you may have a reasonable normal 911 response time of 90 minutes.
Yep.
You also then may take that same patient on an interfacility, which takes 8 hours.
Yeah. So again, the average trip time, you're going to average. So average takes the high end, right? So agreed. So here's the thing is they're going to ask for it generally on your average time, and then they're going to ask you for a subset of that time so that they start to understand, hey, their average is, let's just say it's 4 hours, but their average emergency response time, which is going to get asked in a minute, that may be 90 minutes. So they'll get an idea, right, about how, and you will also have to provide a percentage, what percentage are in each HCPCS code. So they'll know, they'll start there. It's interesting. I give them credit because I think they did engage the industry to get the minimal data points that would really get it cost. And what we were trying to get at here was the cost of readiness, right? And so, because if I ask people, what is the cost, defined what elements or what costs are in the cost of readiness, they really have a hard time doing it. And so we're sort of like the Supreme Court's definition of pornography, right? I can't define it, but I sure know what it is when I see it. And so what I'll say is, this is getting at some of that. So as they get through these questions, you're going to see that they slice and dice the information based upon emergency, non-emergency. So they'll ask you, so both in your primary and your secondary service area. All right. And then they're going to ask you about your emergency response time. That's from the time when the call comes in to when an ambulance or another EMS response vehicle arrives on scene. What I tell people is your EMS response vehicle arrives on scene. Okay. Not if you're a county-based system and your sheriff arrives on scene and they're providing EMS services, fine. But what I really mean is you're not responsible to necessarily figure out if some other entity arrived on scene. get your data. Then they're going to ask if you have any response time incentives or targets, right? Some of those targets are established by the local city or town. Some of those are internal. If they're internal, hey, we just really want to make that time. They want to know that because that's your choice. But if it's something that you have absolutely no control over, hey, you need to be to 90% of your trips within 5 minutes and 59 seconds or face a penalty, they want to know that because that does go to cost. Again, if you internally set that, we'll be there in 4 minutes. That's your choice. That's different than, hey, if you're not there at a certain period of time, we're going to penalize you. Does that make sense? All right. So ground ambulance transports and volume. They're going to ask volume and other information relative. So they want to know what's your ground ambulance transport volumes and what number of the transport did you get paid. So fully staffed, equipped ground ambulance responding to a request for service. So transports, not just simply not any vehicle, but ground ambulance. So as defined, right, by Medicare, fully staffed and able to transport a patient. You may have ambulances that are licensed in your state that aren't able, like Massachusetts Class 5, a Bronco, I'm showing my age, I'm sorry, an Expedition or an Explorer. Those might be a Class 5 ambulance or a special ambulance, but they can't transport. That's not what we're talking about here. We're talking ground ambulance transports. And then they're going to ask, did you get paid in full or in part? They want to know, even if you got $2 for the trip, they just want to know, did you get paid in full or in part? It will play itself out in the numbers later on when they're looking at revenue and volume, if that makes sense. They will ask you your total number of responses, whether you ever dispatched a ground ambulance or not. So in other words, what total number of requests for services did you functionally get? Whether you ever dispatched a ground ambulance, but you may have dispatched something else, you may have gotten canceled shortly after you got the request. All right. Ground ambulance, total ground ambulance responses in any reporting year. So there's total number of responses, whether a ground ambulance was sent. So you may have sent fire apparatus, you may have sent, some other apparatus, but then they're going to break down as a subset of that. Well, what were the total number of ground ambulance responses in that year? Here, that's where we capture that. All right. Got another question? No? Okay. So here, when you're in here, you will be generally producing data or transports by HCPC. Now, I know this can be challenging in some. This is why when people talk about their billing agent's going to handle this for them, just recognize that like 89% of this cost collection tool has nothing to do with the part that most billing agencies have anything to do with, which is revenue. All right. So just recognize that if they're going to offer to do it for you, you want to make sure that you understand exactly what's included in that scope for service and how, by the way, just so you know, if they offer to do it to you and you're going to pay them more money, recognize you're going to be the one furnishing 90% of the information. So you really shouldn't be paying for it because you're going to have to do 90% of the work anyways. So they are going to ask you by HCPC. Okay. And this is how that volume gets played out in Amber. So they will, again, they will ask more ground ambulance service volume, response with non-transporting agencies. They will ask you if you do responses with non-transporting agencies. They will ask you ground ambulance responses in your secondary service area. In other words, what percentage of your ground ambulance responses occurred in your secondary service area? And then how many of those did not result, not those, but all ground ambulances responses did not result in transport, all right? In many instances, some of these things do overlap because there is a little check and balance built into what will be, I'm told, will be built into their tool. They are going to ask you about standby events because those are committed resources, paramedic intercepts, and then ALS joint responses. Okay, so just to make sure that folks understand, if I get a call for a single car accident with one patient and I respond to ground ambulance and that ground ambulance transports one patient, that is one ground ambulance response and one ground ambulance transport. If what comes in is, a school bus that got hit at a train crossing and I unload the barn, I send out 5 ambulances and we get there and there's only one patient, that is 5 responses with 1 transport. I'm sorry, I just lied. You did dispatch 5 ambulances, but you had 1 response because only 1 patient was transported. If they transported 2 patients, you had 2 responses and 2 transports. So point being is if you dispatched ALS and BLS, that counts as 1 response. All right. I'm not sure why they did it that way, but they did. All right. The final was they asked you if you got paid. So what they're looking to, the sort of final proposed rule, the proposed and then final rule here was what they wanted to make sure was of the ground ambulance transports your organization provided in a particular year, calendar or fiscal year, how many were paid either across all periods, regardless of level of service or geography by the time that you reported your data, right? So presumably, if you're reporting your data 5 months after the close of your reporting data collection year, pretty much most of your stuff should be collected at this point. What they're looking to avoid is what monies they're not looking to collect. If you collected $150,000 of VA money that was 6 years old during that collection period, they're not looking to capture that revenue data. All right. So just so we're clear. All right, service mix. They're going to ask ground ambulance responses during the year, response levels at ALS, BLS. That's part of what I showed you in the Amber tool earlier. They're talking about an emergency is an immediate response as defined by Medicare. All right, that includes emergency transfers, really are emergencies from a lower to a higher level acuity. I know those occur all the time. And then they do ask for a combined emergency and non-emergency because they're doing a little check and balance. All right, this is that, hey, give us a breakdown of the percentage. What percentage of your organization's ground ambulance transports fell in the following categories? They ask you by HCPCS, non-emergency, emergency, BLS. So BLS, non-emergency, BLS, emergency, ALS1, emergency, and non-emergency, ALS1, non-emergency, ALS2, and then SCT. You should be able to get these pretty easily. They, of course, also provide you with the definition. I think this is relatively straightforward at this point. They will ask you what percentage of your transports were interfacility. That is from one facility, certified healthcare facility, to another. So that includes SNFs. All right. Now, you may have an emergency at a SNF that goes from one facility to another. That's okay. This is a separate question. What percentage of your total transports occurred from one facility to another? All right. Section 7, and I know we got about 24 minutes left here. So I think we're pacing right. Section 7 is the labor section. This is generally the largest section. This is the largest piece of overhead that any ambulance provider has. So usually represents anywhere from 57 to 70, almost 80% of overhead cost for ambulance providers. So this is the largest section of the tool. They only want the labor of those individuals who are either partly or entirely related to ground ambulance. So if you have someone who's in fire and inspectional services, they're not, and that's all they do, they're not looking for that information. All right. They're not looking for any contracted help either. They divide labor into 3 large categories: EMS response staff, EMT response staff, admin or facility staff, or medical director. EMT and response staff is anybody who at any time responded to a call, regardless of what they do in the organization, at one point during the reporting year. So if I'm the chief and I responded to a medical call during the year, I am EMT response staff. Even if everything else I did all year long was administrative, if I did one ambulance response in a year, I am an EMT response staff. Admin or facilities, pardon me, are those folks who never respond at all, but are either partly or entirely related to ground ambulance. So fleet technicians, billers, dispatchers, HR people, all of those folks. Medical, and by the way, if you have staff that never actually respond to ground, they could be certified, but they never respond to ground ambulance calls, those are admin. So if they're doing education, onboarding, orientations, that kind of stuff, but they never go on calls, even if they're certified, those people are not EMT response staff. By the way, it is based upon the person's position at the beginning of the reporting year. So the data reporting year. If I started out as an EMT and my year is a calendar year, in January, February, March, I'm an EMT. April, I become a paramedic. You are going to report all of my yearly labor costs as an EMT. I think this is probably one of the dumbest things they did, because it would be far more accurate to say, give me the number of hours and give me the dollars associated with EMS, because by the way, in EMT response staff, you are going to break it down by EMT, paramedic, etc. So you are going to want to, you're going to need to be able to, this is the one thing, anybody whose status changes during the year, you're going to want to make sure, all right, that you tack them to the right, even though they may be a paramedic at a higher cost. This is how they did it. I'm not really sure why. You will have this checklist. Yes, Kim.
You noted the medical director there. In many cases here in Colorado, the medical director is not compensated by the agency. They're compensated by their healthcare system, et cetera.
So it's
How
like
do
an
we-
affiliate medical director?
I'm sorry?
It's an affiliate medical director for which I'm presuming you have a contract with that hospital for medical director services?
No.
Oh, I just heard
In-
yes and no.
Well, in my case, in many cases, the medical director is given to the agency by the healthcare system. This is not a stark issue apparently, but
That's okay. Yep.
they just provide the service. Some agencies provide some compensation. Most rural agencies provide no compensation, but the value is still there.
That's okay. So there are a couple things you can do. You can have a volunteer medical director, and that would be reported in the labor section. You could have someone you issue a 1099 to, I'm sorry, not a 1099, a W-2 to. That would be reported in this section. If it's somebody who you contract with the facility for those services, then you would report that in a later section in the tool under contracted costs. And if it's donated to you, in other words, let's say you have, I believe, donation of medical director services, I want to say is reported. God, I gotta take a look at the tool, but I believe it's reported. If it's donated, I believe it's reported in the other tool where you would report the 1099 labor. But yeah, so that's not uncommon at all. That's not
Thank
uncommon.
you.
Yeah, sure. All right, so here is where you're essentially telling the tool, and this is the Word version of it, but here's where you're telling the tool what kind of people you have working for you. And I don't mean like, well, what kind of person are you? No, I mean like, what are the nature of the categories of the folks who work for you? There's nothing fun or there's nothing funny or exciting about cost collection. I'm sorry. I try, but it's sometimes a little dry of a topic. So, all right, here you'll see it's broken into those categories: EMT/response staff, medical director, or admin/facility staff. They're going to ask you to check whatever box applies. So that first column says paid staff without fire public safety roles, if appropriate. Second one says volunteer staff without fire public safety roles, if that's appropriate for you. Next column says paid staff with fire public safety roles. Then the next column says volunteer staff with fire public safety roles. You just want to check whatever box actually applies to your organization. All right. And then this sets up the tool moving forward. So as you can see, clerical, human resources, HR, IT, billing, etc. You just check off whether those are folks who, lots of places have people who also do, let's say you have a firefighter who also happens to be your HR person. It'd be interesting. But, you would just check off whichever one applies or is appropriate. All right. Here is from the Medicare Learning Network, that CMS page, staffing and labor costs that were done on February 6th of 2020. It's a great, this is a lot on this page and I'm not going to go through it all, but essentially we like algorithms in EMS. If this, then that. This is one of the many tools that will really help you as you work through, okay, where or how does this person fit in from a categories perspective? I would suggest that you take this algorithm, go through your list of employees and categorize them. This is part of why we're talking about this now, because many of the software systems that folks use, whether it be scheduling or others, and some folks may be using a spreadsheet. If that's the case, what you want to do is make sure you create a crosswalk or a category in that spreadsheet, or in your systems usually have additional unused fields that you can then say, I'm going to create a cost collection field so that I know, not only I know, but someone moving forward knows this person belongs in this bucket. All right. Again, this is the amber version of this. Those blue circles or question marks give you an explanation and a definition of what those folks mean. Again, number of paid staff, number of all those blue question marks will, when you mouse over those, will take you to the underlying definition or will give you more clarity on what's expected in that area. All right. So here is where you're going to report your compensation in hours. This is important, by the way, in particular for volunteer agencies. I know at my fire station, we would generally we were paid, but what was considered working hours was from when the tone went off to when we were given the all clear. After everybody got back to the station, we checked out the equipment and we sealed up the bags and left for the night. You are going to need to track the volunteer hours, not only those who are paid, but also the hours of anybody performing volunteer services. This is the part that most people usually roll their eyes at me and they go, oh, the fact of the matter is there is a mechanism for doing it. You're going to need to track those hours, okay? The hours and any compensation associated with it. So they're looking for here, as you look at this, it says total annual compensation for EMT response staff in dollars, total hours worked annually for EMT response staff. And that is broken down by basic, EMT basic, without, EMT basic with, public safety roles, and it works its way through. All right, now compensation includes the following items. All right, that's wages, salary, overtime, training time, standby time, benefits, healthcare, PTO, retirement, stipends, life insurance. If those costs are borne by someone else, let's say you're in a fire-based EMS system and you're in the town's retirement system or on the town's health plan, that may not get charged directly back to you in a budget line, but you need to go get that information from your town. All right, so again, these are all of those, any sort of compensation. CMS just recently did this one in October where they show you an example. If you have an EMT basic that makes $20,000 a year, the whole 20,000 goes into that EMT basic. If you have two paramedics, one who makes 38, one who makes 42, then you combine those. It's pretty straightforward. This is why what I don't understand is why, rather than tacking somebody who changed status in the middle of the year from an EMT to a paramedic, it would be easier for us to actually just pull the dollar figure of paramedic hours and wages. So much easier than it is to now have to back somebody out because 6 months out of the year they were in there. I see Tim, a new question, or Tim's like, I just want to go to the restroom. So yeah, Kim has to unmute you.
Is standby time the same as on-call time?
So
some volunteer agencies are providing on-call pay.
So, yep. If you have some sort of, if they're standing by at the station, let's just say they're like, you require that, it's standby while they're sitting around waiting for calls to come in, you require, then those hours would be counted. If this comes back to the waiting to engage, engaging to wait. So if a volunteer or an employee is free to do with their time, whatever they do with their time, then those really aren't working hours. If, however, let's say you're actually restricting their ability to go do stuff and you're actually paying them, for being on call, right? They're on call, then you should be tracking that time and those hours, all right, that money in those hours. All right, I will skip this one because honestly, as we look back, it's very, very similar, just goes through how those hours are sorted out. All right, now it could be very well, by the way, that paramedic B or paramedic C, right? If that paramedic C did no hours, total hours worked related to all other responsibilities by employees, right? Those total hours worked. If in fact what you're going to have are total comp annual, total hours annually, total hours worked related to ground ambulance, total hours worked annually related to non-ground ambulance responsibilities. All right, so and it should work out to be that that those are a check and a balance. Same with the administrative folks in the organization. All right, you're going to report those. These all come right out of that Medicare thing. Honestly, they did an amazing, amazing job, and I have to give credit where credit's due. Oftentimes we beat the heck out of our federal partners, but this is an instance in which they did a really nice job. Here again, public safety. They have they have an entire webinar on how to deal with labor. In fact, this one's been updated more recently. They just did one. I missed it, but I have to go back and watch it. They updated the one on labor. It did not actually caught the tail end of it. They didn't change dramatically. So you just want to go through and be able to identify those who have with or without other public safety roles. And again, here's an instance in which you will report total compensation, total hours worked, and then total number of hours worked unrelated to ground ambulance. So you are going to have to understand what percentage of those hours. So if you have someone who does some time on the fire truck, sometime on the ambulance or fire truck responded to ground ambulance calls, but then sometime working, not in fire, what you're looking to get are those hours unrelated. So if, let's say, for example, your average staff member works 48 hours a week, 50% of your call volume is tied to ground ambulance. To the extent that you're able to definitively say what those hours are associated with ground ambulance, fine. To the extent that you are not, you could arguably do some calculation based upon that, so you could identify. If you have, let's say, someone who only does fire inspections and permits, well, then that person's stuff, if they don't ever do ambulance calls or anything related to ground ambulance, they're not even going to be on here. All right. So now, again, volunteer labor, you're going to be tracking those hours related to and not related to ground ambulance by that same thing. And so here they're getting at, hey, what are we talking about for time? Really, they're talking all hours worked related to ground ambulance, all hours worked related to that fire or other public safety role. And then, by the way, they're not looking for time spent on call. And what they mean by that is, if tonight's my night to be on call, I really otherwise don't get paid, and really I'm never ever used for anything, well, you're not going to count those hours. But if you're actually paying those folks, they're sufficiently restricted that they can't really go anywhere, then that and you're paying them, then you would report that. Otherwise, again, if they're out there with the boot, you're not going to be tracking that time if they're out fundraising or doing stuff like that. All right. If you had, in fact, admin staff, because there are often people who are admin staff during the day, but then perform EMS duties at night, those folks will all be reported under the EMS response staff, period. Facilities, I know we're in the last 9 minutes, so I will rock and roll. Facilities, they're only looking for those facilities entirely or partly related to your ground ambulance. All right. Here, they're going to ask you to name how many facilities do you have, and they want you to name them. You can create whatever name you want. As you name them, it will carry forward in the tool. So once you've said we have 3 facilities, you will not see spots for 4 facilities or 5. You will only see those 3, and they will carry forth in the other parts of the tool. They want to know if you made lease payments, if you actually, or another entity owned that garage, made mortgage payments, whether you own the facility outright or whether that facility was donated, what was the square footage, and what square footage percentage was associated with ground ambulance service. So if you're in a firehouse, or you're a fire station, and 30% of your station is tied to ground ambulance, well, then you would put that figure in there, just like this. All right. So same with leasing, any leased or mortgaged properties, they want you just to complete that portion of it. You populate those. And then they're going to ask you for any of your facility insurance, any maintenance and improvement, or utilities and taxes. So they're going to want the total amount, and then that same percentage that would be affiliated with your ground ambulance. What I would suggest is show your work in some documents. The people, if they come back to ask you, or somebody else has to do the reporting or finish it, they want to know how you did it. All right, that same stuff here in amber. So it's really nothing crazy. All right, vehicle costs. This looks very much like the facilities cost. Do you own, how many ground ambulances do you own, and how many do you lease? How do you depreciate those vehicles? You're going to follow whatever depreciation, as long as it's generally accepted accounting procedures, you're going to follow whatever depreciation you would normally follow. They're going to ask if the ambulance did any transports that year. If it didn't, that's fine. You're just going to say, was this ambulance used to transport patients in a particular year? If you check yes, great. If you check no, great. Just don't report that you did when you didn't. Was the vehicle donated? What was the annual depreciation, if any? Was the vehicle remounted? And if so, what was the cost of that remount in that year, by the way, in that year? Did this vehicle transport for leased vehicles? And what was the total lease cost during that year? They will get at other non-ambulance type vehicles. All right, so these are all things that were used to respond to ground ambulance call or support ground ambulance calls, all right, do not include vehicles that would meet the requirements for ambulance. Let me say that as a caveat. If it's a class 5 ambulance that can't transport a patient, I would include it here. All right. How many vehicles, non-ambulance vehicles, did you own that were used to respond to ground ambulance calls or support ground ambulance operations? That would include fire trucks, land, water rescue vehicles, etc. All right. That would include gators. That would include boats. That would include, it wouldn't include horses, I don't think, because I know Matt used horses in Fort Worth. What were the total number of miles by non-ambulance vehicles for any reason? Did you have any non-ambulance water vehicles that may, and then depreciation? One of the problems with water vehicles is we don't tend to measure miles. In this instance, you would do your best to estimate, but show your work. All right. And then here, again, you're going to fill in, once you've listed what those vehicles are, it's going to ask you what type of vehicle it is. Was it used to respond to ground ambulance or support ground ambulance calls? Was it donated? What was the amount of annual depreciation? And what percentage of those miles were associated with ground ambulance? All right, same thing here in amber. They're going to ask for your total registration and other costs. All right, insurance, etc. That's for ambulance and non-ambulance. All right, what was your total maintenance cost? They're going to ask for those maintenance costs and what was attributable to ground ambulance, fire trucks, land, water, etc. This stuff's all really pretty straightforward. Same thing for fuel. What percentage attributable? If you get your fuel from somebody else, you have to get that amount of money. Say they donate it. You are going to need to know what was the essential cost of the fuel that you used. All right, consumables, and I know I'm running late, sorry. You're going to get both capital and disposable equipment. You will list that. So what they're going to ask you for is your capital medical equipment. What were the annual depreciation amounts? What were the maintenance and the cost of those? They will separately ask you about medications. They will then ask you about consumable, throwaway medical equipment. All right. And what were the total costs of those medical gauze, etc. Non-medical equipment. This is everything in your station that isn't used on patients per se. So it's going to be phones, filing cabinets, desks, the chairs that you're all sitting at, right? All of that stuff, dispatch equipment, computers, telephone systems, all of that. And then separately, uniforms. All right. And that is it again in amber. So last, they're going to look for any outside contract services for those who use billing, accounting, vehicle, dispatch, facilities, maintenance, IT, etc. You're going to list did you use any of those? What was the cost and what percentage was attributable to ground ambulance? This is a mess. There's a lot on there. I know you probably can't see it so well, but these are all of those other administrative, medical, biohazardous waste, physician fees, fees paid to other non-transporting board of directors, trustee expenses, IT, software, fines, fees, etc. You are going to answer yes or no. And then you will list in any other costs, all right, that you have to identify what was the amount and what was the percentage attributable to ground ambulance. And then there's a total cost, which is your check and balance. Now the easiest, and this is that same section in amber, your easiest section is coming up right now. All right, this is revenues. I say easiest because this should be pretty straightforward. Please report your total revenue from all sources organization received during the year. They want it by traditional fee for service, Medicare Advantage, traditional Medicaid, Medicaid managed care, TRICARE, VA, commercial workers' comp, and self-pay. You are going to need to ensure your system has the ability to work those out. In particular, comp often looks like other commercial insurance. You are going to need to split those out. Did you receive it from those? Yes or no? What amount was it? Was there any cost sharing amount included? So if you had a deductible, did you include the cost sharing amount up here? Don't include it down here. All right. So if somebody had a deductible, then they will ask you again, did you receive revenues from bond, debt sales, taxes, any other matching grant program, special? You're going to list those in and how much and what percentage of that revenue was attributable to ground ambulance service. Same thing here in amber. We're near the end. Then at the end, they will ask you, they will do sort of a, hey, look for issues. And this will be in amber, a, hey, we think there's a problem. This is like the red X in any PCR system that says you still have a mistake here. Questions? I know that was a little bit like riding a horse by holding onto the tail, but we can go into any one of these. And if you become a subscriber, you're able to access those videos and some of the other educational content that's already on the AAA website, and you can watch that stuff, and it goes into detail into each section of the tool. And I'll always come back.
So Scott, as far as revenues go,
Mhm.
you know, are we going to collect or report the revenue from the call in the reporting period, or say it's going to be all revenue from January 2022, which would have included revenue earned from the prior year?
Yeah, so that was that modification that they made to this final rule. They're looking for the revenue that you made from the calls performed in that day. So by the 5th month, right, that you finally report, the majority of your revenue from those calls are going to be collected.
Yeah, and I guess my question is it all the money from January 2022, all the revenue that we collect from January 2022?
I get it. You're saying, is it a money received during the collection period,
Yes.
or money received for the calls performed within the collection period?
Bingo.
Yeah, and my understanding of this latest rule, we're waiting for the final rule to be published, right? So they published the proposed rule, then they will finalize the rule. My understanding is what they've said is no. We want the monies collected from the transports performed during the reporting year.
I
Right.
thought so, but
That's and I will, when the final rule is reported, Kim, maybe we do another quick catch up Q&A, and I'm happy to do a Q&A anytime for folks. And then, you know, certainly you can submit and actually there isn't, I don't know why I haven't fixed this damn error. It is not happy at ambulance.org. It's hello@ambulance.org. Sorry. It's the Happy Fox system that we log all the questions in. So it's hello@ambulance.org. Alternatively, certainly you can email me, S.Moore@Moore EMS Consulting. But if you go on the Amber Cost Collection Grant, it's on this page right here. SAVIC Foundation, certainly we're more than happy to answer any questions. But again, I know we're at the top of the hour, but here is the place where you submit your questions. So I'll wait for that final rule. That's a great question. I'll wait for that final rule. That was the modification. And I think the answer is going to be those as specified specifically for those calls that were done during that particular reporting year.
So given the fact that you did a call in early December of calendar year,
Yep.
you don't get the money until January or February of the next year, are you just supposed to estimate, or do you have to not turn in until you've collected all debt?
So what you're going to do is, and like I said, the devil will be in the details when they release the final rule. All right. They said that they finalized the rule. They just haven't published it yet. My belief is if you did a call in December, but that's not in your reporting year, you're going to report calls that you did on, you know, at 12/01, January 1st. You will do all those calls during that 12-month period. You will record that revenue during, you know, that you received from the calls performed in that period. So not for the ones performed in December, right? But again, I want to wait until I see the final rule, because before there was a lot of confusion. It wasn't clear. Hey, if I'm an accrual-based accounting or a cash-based, there was too much confusion over what we were talking about for revenue. So I believe we'll see that final rule published in the next week, maybe two. And then once I see the actual hard and fast rules with any explanations along with it, I feel like I can answer that question more clearly, but we'll know. All right. I'm sorry. I wish I had a better answer for you, but it's my belief what they're looking for is the revenue collected from the trips performed in the report data collection year. Okay. Not for once, because you could collect $100,000 from the VA that's been outstanding for 3 years, right? In that year, they're not looking for that money. That's not an accurate reflection of what revenue you received.
Cool. Thank you.
Yep.
May sound like a dumb question.
No
but
dumb
when you're
questions.
talking about the urbanicity of the service, urban, rural, super rural, do you report how CMS sees you, or do you report how you see yourself?
So you're not going to identify where you're rural, super rural, or urban. You will identify your zip codes, and they will assign you rural. Yeah. Yep. Good question. Not stupid at all. I remember in law school, I said, I think, you know, professor, I think this is a stupid question. And I got totally slammed by him. He goes, there's no stupid questions, only inquisitive idiots. I was like, damn. It wasn't the
Okay,
first time he made me
another
feel like,
one is, so you referenced your encyclopedia definitions, and my guess is seeing that Amber does include like fire service reporting. Are all the definitions, have they all been agreed upon by like the IFC, AAA, NAEMT?
fair question.
So we are truly, for the first time, speaking the same language on everything.
So what I did in the definitions were where a Medicare definition existed in Medicare vernacular or in their documentation, we used that, even if arguably it was from a different entity type, right? So in other words, if we were talking about facility, we basically used, if it weren't either in the cost collection, we used whatever acceptable definition. CMS has seen those definitions. I cannot tell you that, and frankly, I don't believe the IAFC and the others would necessarily sign off on those definitions because, by the way, the encyclopedia has a lot more definitions than is required to be reported in cost collection. So it's my understanding, and I'll tell you that the CMS tool itself has very specific, delineates very specifically what information they're looking for. I think they've done a pretty decent job in trying to narrow the window for variation. But I think while we're collaborating nicely with those groups right now, I'm not confident that we'd ever have universal acceptance. I'm sorry, I can't answer that question better. I would love to tell you, yes, we vetted those, but truthfully, I'm not confident if we sent over the definitions that they would have given per se its blessing, truthfully.
Any other questions?
And then just a comment too, anybody who is a member of MSAC is also a member of SAVIC, and you can apply for that grant for Amber because you're a member of MSAC.
And I'll just say one last thing, Kim. Anybody who's on this, I like the Colorado RETAC. You guys just don't go it alone. Send an email, send me an email, call me up. Kim, I think, and Tim can attest to the fact that I don't ever let those messages go for a long period of time without trying to respond. And I'm more than happy to answer. Don't wing it. I'd rather you ask. So.
Thank you, Scott. And
Yeah.
I will attest, you are very good about responding.
Sometimes it takes a little longer lately because
It may not be a quick response, but you
I've
will
done,
respond.
well, we get paid by the word. I've done a lot of vaccination related nonsense, which has really tied me up over the last few weeks. So I apologize for how slow things have been, but, and I think I'll be seeing you all in about an hour. Not quite.
Yes, sir. You will be back at 3:15 Colorado time.
5:15 my time. Perfect.
All right.
Well,
Thank
thank
you,
you, folks.
Scott.
I appreciate the time and attention. Thanks. Bye-bye.